What I want to do now is talk through with you what causes these gaps. So one of the reasons why physicians that are employed lose money is because of productivity gaps. And productivity gaps are caused when production in RVUs and revenue is less than compensation. So for example, a cardiologist, the normal compensation per RVU for a cardiologist would be $50. And if you employ a cardiologist and you pay him $500,000, and instead of producing 10,000 RVUs, he produces 9,000 RVUs, you have an imbalance between compensation and production. Well, some of the things that cause that loss from productivity is ramp up of new physicians who have upfront guaranteed compensation. So when a private group adds a doctor, they usually do it once the group has enough production and each guy is like 110% busy, and they'll add a new guy and shift volume to him and maybe take a little sacrifice on compensation in the short term, make the guy start at a wage that's kind of low, and make him grow his compensation. Well, when a hospital does it, they may bring in a guy, pay a fair market value compensation right up front, add the guy well before they may have enough volume, and there's a ramp-up period. They may have a compensation plan that's not aligned with productivity. And those kinds of plans, of course, are older, but there are still some hospitals that employ doctors and don't connect comp with productivity. Another cause can be where the physician is not full-time clinical, and the other time that he spends, say, in administration or other activities that are not clinical that are important for the hospital but don't drive revenue to the practice are not paid to the practice, and so you end up with this productivity gap. Rates can be another reason why. Oftentimes, hospitals will acquire a practice, and what they'll do is they will then negotiate with payers for rates across the health system, and sometimes they'll offset the rates for the hospital for higher per diems and offset the rate for E&M codes or other physician codes because the overall health system makes more money, but they offset those rates and know that money does not flow back to the practice. Also, it is also the case because in some health systems where the physician side is so much smaller, it kind of gets relegated to the back seat, and when payer negotiations go on, they don't focus on contracting for the physician rates, and they're not very well managed or negotiated. One of the big areas where the loss occurs when you see a loss is revenue is less in employed practices because all of a sudden you will stop paying service agreements to the practice. So one example we have of a client is they were paying a subsidy to a private anesthesia group for anesthesia for OR coverage in excess of volume in the ORs because the hospital was trying to promote access to its surgeons, so they wanted to have enough OR time open. Well, who pays for that excess time? The hospital subsidizes the anesthesia group. Next thing you know, the hospital decides to employ the anesthesia group. The anesthesia group now has a large loss. They ask, why are you losing so much money? Well, remember, the $1.2 million subsidy you used to pay now went away, and now the practice loses $1.2 million. Sometimes the hospital will go provider-based, and you'll see facility revenue from E&M codes shifted over to the hospital, and it's not accounted for in the practice. And then sometimes when there are contract payments between the hospital and the physician group, or other contract payments, for example, that a group may have with the nursing home or something within the context of the health system, many times those contract payments are not accounted for inside the practice. Another reason is staff costs. Oftentimes the higher hospitals have a higher wage base and benefit cost than the practice could possibly ever afford. There are often inefficiencies from the acquired practice that's not remedied. I mean, one of the reasons hospitals buy doctors is because the doctors often get into economic challenges, and the hospital acquires them and then doesn't remedy the very challenge that the practice had to begin with that caused them to be acquired. And then sometimes as the practice is trying to develop new sites where they may not have a sufficient volume, well, they have to staff those sites, and many times they over-deploy staff for a very good reason strategically, but operationally it creates a loss in the practice. Revenue cycle gap happens in every practice, employed, not employed. Oftentimes the revenue cycle or the billing and collection process results in losses. And it's generally driven because daily process is not maintained, a good discipline on daily process is not established, or it's not managed well. And again, hospitals can sometimes fall into the trap of acquiring a practice, viewing the hospital billing piece kind of as a separate piece, don't really take care of it well, and you lose 2 or 3% of your daily process. Next thing you know, revenue drops by 2 or 3%. Sometimes they'll combine the physician billing department with the hospital billing department. That does not work well. They need to be kept separate. They can be managed at a high level together, but their processes are very different. And finally, many times the hospital will acquire practices, bring them in, convert them to new billing systems, and the ramp-up period and the conversion period creates cash flow shortages in the short term, and it creates losses, particularly if their cash basis accounted for. Another reason why physicians lose money is the hospital will have a mission or a policy that takes all patients. And they tell the practice, well, yes, before you used to manage your charity care and your Medicaid patient base, but our mission says take all patients. Next thing you know, the revenue in the practice drops day one because it has a lower payer mix. It can also deploy practices or new physicians into markets where they're trying to take advantage of volume, even at lower payer mix. We have one client that is in a state that generates state-funded reimbursement to hospitals for disadvantaged patients and uncompensated care. And so they're always actively looking for where they can exploit the marketplace for volume, even at a low payer mix, because they get subsidized by the state for that. And another reason why is, even though some hospitals don't have real rigid policies in terms of types of patients for the employed practice, they're willing to let the employed practice see whoever they want. Oftentimes when the practice becomes employed, because the physicians are often then paid on productivity, like work RVUs, the patient schedules go unmanaged. Next thing you know, the payer mix shifts. Another reason why is in all the other costs. So we've talked about staff cost a little bit, but oftentimes when they employ a practice, they'll move it into the brand new Taj Mahal building that the hospital just built as this new MOB, and next thing you know, the practice will end up with more rent than it could ever afford on its own. Oftentimes they'll bring it in and begin to implement EMR on a very robust, expensive EMR system that the physicians were hesitant to pay for and probably couldn't afford, and they allocate that cost over. And then many times they'll also begin to incur new cost in marketing as they try to grow the practice. Utilization is an area that drives some of the loss, not as much as some other areas, but it does. One of the areas is the fact that when a hospital takes over a practice, many times they'll have the practice shift procedures that were previously done in the practice over to the hospital, primarily either because of a cost savings or to increase reimbursement from better reimbursement on the hospital side. Many times the technical component procedures will now be billed as facility-based, and you will see that the average reimbursement per test will go up, but the distribution of revenue to the Part B side of the practice will then drop. And then you do have occasions where physician procedure utilization is low or undercaptured, where you'll have one internist who just doesn't do very much lab work, doesn't do very much injection work, doesn't really do any imaging of any kind, is pretty 95% E&M based, whereas the typical internist will be about 70% E&M based, with about 30% revenue come from other procedures. And you have to look at that utilization and talk about why that physician is a low utilizer. Coding can be a problem where there's low coding. It's not really ever driven by the acquisition itself or being employed. But just generally, when you look at physician economics, low coding can be a problem, either from poor documentation or compliance pressure where physicians are afraid to code right, or a lack of education. And finally, a real minor one, and that's the charge master. Sometimes practices have charges on fees that are less than Medicare, And of course, then when you have indemnity payers who are paying you a fee or the greater of a percent of Medicare, then you get lower reimbursed. So when you put all those together in that practice loss, and you look at this $5 million, the next thing you have to do is to assign that loss. And there's 3 buckets you put the money into. You put it into, oh, this loss is strategic, this loss is an offset, or it's operational opportunity for improvement. If it's strategic or offset, you leave it alone. If it's operational, you take action and fix it now. So an example of that would be, and again, this distribution is a typical distribution of what we find where the money should be allocated. So for example, under productivity, a portion of that may be where you have physicians who are participating now in hospital programs to improve hospital quality, lower cost, and so you take some time away from their practice to focus on that, and you don't necessarily want that to change. A portion of that can be where you deploy doctors into markets where you're trying to expand market share and they have low volume. You don't want that to change. An example of offset is where you have a physician that might be, this is a good example with hospitalists. Hospitalists will often have a loss, but there's an offset on lower length of stay. And so there's an economic offset in places. But we find that about half of the productivity issues that exist in hospital employee groups are things that you should fix. They are true improvement opportunities. The rates is an example. Usually there's an offset of rates, so where they have low rates on the physician side, the offset is where the hospital rates are higher. You'll find other revenue. So you may find that the other revenue that usually exists in a practice isn't in the employed practice. Well, where is it? Well, it's because the offset is where the hospital no longer writes the check to the practice for coverage and call, etc. So this is a typical distribution of where it is. We find that about half of the money, 40 to 50% of the loss, is usually something that you can work on to improve. So in this $100,000 loss per doctor, about $19,000 of it strategic, you leave it alone. About maybe $38,000 is offset, you leave that alone, and you work on this $42,000 so that if you were to make those improvements, you would end up with about a $60,000 loss per doctor. When it comes down to taking action on the operational improvement opportunities, we find it's a real challenge to get people to take action, because there are things that you really have to do that are often either very difficult to do, very risky to do, or in many cases they threaten the very hospital strategy that you employed the physicians for in the first place. But when we talk about taking action to exploit those operational improvement opportunities, you have to, an example is, if you want to reduce that loss, stop adding new physicians. If you want to reduce that loss, you actually have to terminate unproductive physicians. You can go talk to them, you can go lecture them, you can often shift compensation plan, you can go threaten them, but at the end of the day, when you have low producing physicians and you don't have enough money or you need to reduce that loss, you need to terminate the physician. You can put physicians on RVU or virtual comp models if they're on some kind of a fixed base model today. A virtual comp model is where the practice is essentially revenue less expense plus some funding equals their pay, and they have to manage the practice revenue and cost along with the funding. That's kind of a virtual comp model. You can cut back or eliminate non-clinical time. So maybe you can't have those doctors participate in so many quality programs because it's threatening both compensation as well as the subsidy. You can implement expected hours and schedule templates. What we find interesting is many hospitals will have contracts with physicians that will say, we expect you to work full-time, we expect you to dedicate your full-time effort to being a physician, and then the physician gets to drive what days he works, how many hours he works, how many sessions he has. You can stop deploying physicians to low demand and redeploy physicians to high demand areas. You can close unproductive sites. You can cancel payer contracts with low rates and low volume. You can absorb practice jobs into hospital functions, and then you can limit the amount of practice funding. So these are things that if you do, however impossible, however difficult they are, will produce a change in the loss of your practice. Number 10 there would be, we had a 60 physician group that had a certain amount of funding per doctor, and they had challenges with their loss and the income on the hospital side. So they went to the doctors and said, beginning next year, we're capping the loss per doctor at $50,000. That's the subsidy per doctor, and you guys have to work out your economics in such a way to make that work. When you begin to account for employed practices, hospitals will account for practices in three ways. They'll either load the income statement fully like a typical practice, and so they won't strip out the ancillaries, they won't force payer mix, they won't try to strip out rates, they won't have the physician do unproductive work, and they'll end up looking like a typical practice. Some hospitals will take what we call a funded approach, and so they do move ancillaries. They do have the practice move into newer facilities. They do have them take a lower payer mix. The next thing you know, revenue drops, cost ratios move up, maybe they pay them a higher fair market value compensation, and next thing you know, there's a loss. And what they do then is they rationalize each one of those pieces. They'll pay an hourly rate for time in meetings. They will calculate the payer mix impact and subsidize the practice. They will lower the cost of the EMR to what the practice can afford. They will do things to and then assign value and then fund the practice so the practice has a break even or actually has a bottom line that the practice manages to. About half the practices take the funded approach. About the other half will take the loss approach, and that's where they don't worry about the loss, they don't focus on the loss because they're recognizing that the importance of the practice is within the context of the hospital, and they let that loss fall to the bottom line. The typical physician reporting then ends up to often be this polar picture where they separate the entity and you get this over-focus on the loss. So when the board looks at this, no one can look at that picture at the board level and say, now remind me again for the 19th time why it is we lose money on the practice. And the focus needs to be on, well, how does that contribute to the hospital side? So what we encourage hospitals to do is to blend the two income statements into one. So hospitals that report the employed practice within the hospital service lines, they can appropriately manage their investment in employed practices. This is an example, this is a real example of a client we have, where they then blend in the economics of the practice with the hospital. So when they look at revenue, they say, here's our inpatient revenue, our outpatient revenue, and our physician revenue within the context of cardiology or orthopedics, pulmonary. Here's our cost, and here's our profit. So you can see in this case down at the bottom where it says orthopedics is not working, you can see there that the loss on the orthopedic practice is $3.9 million. And they don't make money. They're losing money in orthopedics. And is it just because of the physician side? It won't be just because of that. They'll go in, they've gone in and looked to see where else, what's going on in orthopedics that's driving that loss. You can see on the gastroenterology side, even though they have an $800,000 subsidy to the gastro practice, they are making money. So that allows them to look at the practice in the context of why they have it in the first place, which is to drive overall hospital strategy as well as improve margins across service lines. So in summary, hospitals will spend, you should be spending about 2 to 10% of your revenue on your physician strategy, either both in employed and non-employed payments. It's very normal to lose money on employed physicians. The reason for the loss are found across the 10 economic drivers of practice, and half of that loss is usually tied to hospital strategy or offsets, and the operational half of the loss, you need to fix that. You need to not accept that as, well, that's just the way it is. Those are things that need to be fixed. If you account for the employed practice and the hospital together, then you can kind of appropriately manage that investment and not get this over-focus on the loss. And finally, you can eliminate significant losses immediately, but you have to remember that sometimes they accompany trade-offs on hospital strategy where you may then threaten the very strategy that you brought your employed physicians on in the first place.